Okay, I'm here with Dr. Heidi Klessig. First of all, thanks for doing this. I appreciate it.
I so appreciate you coming up and interviewing me live on camera. This is fun for me. I don't have to sit in my basement.
I know it is. It's fun for me too. I don't have to sit in my basement, so this is great. And we're at a beautiful church with over 100 years old, right? With beautiful architecture. Spent probably the first 45 minutes here just talking about the architecture. So I love coming here and doing these things in person, but there's a lot to talk about today. So I guess we'll just start. I just want to start with your own personal story. Maybe give a little bit of a background as to who you are, and then leading into your personal story that you were a resident in your residency at the UW-Madison Hospital. And I just want to know about your story and what has happened to you.
Yeah. Like a lot of people, I come to this issue because I was sort of blindsided. Mm-hmm. I was assuming that things were more settled scientifically than they truly are in the realm of organ donation and transplantation. And, and always before I begin, because I have no stones to throw, as you're going to find out in a minute when it comes to this issue, I always like to start just offering a message of compassion to people that are going to perhaps be somewhat blindsided by what I say. So I always say, if you're a doctor or a nurse, when you were trained, you were responsible for so much information. There was no way you could possibly investigate it all. You had to take it on the basis of authority. And you know what? Your authorities probably took it on the basis of their authorities. And if you gave a beloved family member to be an organ donor, you made the best decision you could with the information you had available at the time. And it's not your fault that you were not given this information. And most of all, if somebody listening has received an organ, obviously we're so glad you're here. We're not saying that your life isn't valuable. It is. It's just, again, not your fault that the organ you were received may have been procured in a way that might violate your conscience. And this is important for me to say because I am culpable. I came in one night in the late 1990s for night call as an anesthesiology resident. I was doing my early training. I was one of the junior residents at the time. And I reported to the doctor at the operating room desk for duty. And he said, "Oh, Klessig, glad you're here. We want you to go up to ICU. There's a brain dead man up there, and we'd like you to bring him down for an organ harvesting." And, honestly, it kind of shook me. I wasn't mentally prepared. I was quite sure that somewhere along the line, I must have heard a lecture about brain death in medical school, but I didn't have all the facts at my fingertips. So I asked him, I said, "Gee, brain death, huh? Is there anything different about this case I need to know?" And you know what? He laughed. He kind of rolled his eyes. He said, "Just be sure someone has actually declared him brain dead. You know how eager the transplant team can be." Not what I was hoping to hear. But I went up to ICU.
What did he mean by that? You know how eager the transplant team can be?
Well, the transplant team is always looking for ways to help their patients with organ failure. Their perspective is, we know all these people with organ failure are out there, and it's our job to see if we can find viable organs for these people. And so, honestly, when I was doing my pediatric ICU residency rotation later in my training, the transplant team would come to pediatric ICU. They'd make rounds on their patient who was there. And then I hate to tell you this, but they would sort of shop around the rest of the ICU looking at the other little boys and girls. And one time I was sitting at the pediatric ICU desk doing some charting, and one of the transplant surgeons actually came up to the desk and asked one of the nurses, "Oh, I'll make up a name. How's Ashley doing? Not too well?" Their idea is, if you're not doing too well, you might be a very good organ donor. And so I think that's what that doctor at the operating room desk was saying.
And these are people in healthcare, the healthcare industry, right?
Well, people in our society have often a very utilitarian view of people's worth, and so if you're on the way out anyway, maybe you could give your organs to someone who maybe has a better chance, is the utilitarian thinking.
Yeah. Okay, so what happened then?
So I went up to ICU and I found my patient. He was about my own age at the time, a young man who'd been in a motorcycle accident, and he had sustained a severe traumatic brain injury. Yeah. And the neurologist had seen him and indeed, yes, had checked all the boxes on the brain death protocol and had declared this man to be dead. So I went and looked at my patient, and, he didn't look dead. I went in, and here's a young man, and he's warm, he's pink, he's got on his monitor, he has good blood pressure, good heart rate. He wasn't actually on much for drugs, drips, or infusions. And to me, he looked just like every other ICU patient I'd cared for. And in fact, better than most. He was fairly stable, really. So I came back downstairs to the operating room, and I found the staff anesthesiologist who was going to be supervising me for the case. And I presented the patient to him. And he said, okay, what's your anesthetic plan of care? So I was honestly fairly brainwashed at the time. I was being trained to think in a certain way. And I said, well, I think I'll give him a paralyzing agent so he doesn't move during the surgery. Surgeons get kind of cranky when they're trying to operate and people are moving. And I said, I think I'll give him fentanyl as a potent painkiller to blunt any swings in the heart rate or blood pressure that might damage the organs. And so then he said, okay, that sounds fine. Are you going to give him a drug to block consciousness? And I was stunned. I said to him, why would I do that? Isn't he dead? And, that doctor just gave me this long look over his surgical mask, and he said, why don't you give a consciousness blocker just in case? And he walked away. So I'll tell you, this made no sense to me. Right. I'm thinking, what? A dead person with vital signs, and I need to give him a consciousness blocker just in case. But I'll tell you what, to my shame and regret, I just went along with it. Mm-hmm. And I just assumed someone in authority must understand this in a way that I do not. I mean, here I am. I've got an operating room team waiting for me. I've got transplant surgeons waiting for me, people in the ICU waiting for me. I mean, I'm the junior on the totem pole, and everyone else seems to think this is okay. So I did what I was told. Mm-hmm. I went up to ICU. I found my patient. I put him on a transport monitor. I used an ambu bag. I had to breathe for him all the way down to the operating room, put him on the table. I gave him the anesthetic we had discussed, and I'm here to tell you, he reacted, to the incision, the bone saw, the organ retrieval, just like any other patient. He required the same types and amounts of anesthesia as anyone else.
Real quick, so I think that maybe it would be important for people to understand blocking consciousness. One, I mean, there's a whole bunch of philosophical questions we'll get into, but the idea of consciousness, I talked to theologians, I talked to psychologists. Nobody knows what that even means, technically, what consciousness is. But when you're breathing, so my understanding from basic life support is, or BLS CPR, is that when you're adding oxygen to the system, you're pumping oxygen into the blood then when you do CPR, you pump the blood to the brain to keep the brain alive. That's the point of BLS and CPR. So when you're giving that oxygen, is that technically the goal is to keep the brain alive actually? So they knew that the brain was still alive technically. It seems like there's a contradiction here. To block the consciousness of the person assumes that there is brain activity, because I assume that consciousness and brain activity are connected in some capacity. And then to continue to pump oxygen into the system to keep the brain alive, I think that's probably the goal. And you can correct me if I'm wrong on any of this stuff. They're basically asking you to do a bunch of contradictory things, correct?
Well, yes, it is contradictory. But as you said, consciousness, doctors have no tests for inward awareness, right? We can only test whether you're able and willing to respond, which is not the same thing, right? But as an anesthesiologist, when you have surgery, you want to be unconscious. You would prefer not to be awake as the surgeons work on you. So in anesthesia, what we do is we use what's called a balanced technique. In the old days, they used to just bomb you with a huge, heavy dose of an inhaled anesthetic like halothane, and people wake up feeling gross, pukey, hungover. And so to try to mitigate that and help people, get feeling better right away after surgery. Now, instead of just bombing you really deeply with an inhalational agent like that to completely keep you from moving, reflexively having blood pressure swings and being unconscious, now anesthesiologists use a combination of drugs. We do use a paralyzing agent for most surgery, something, if people want to think about, poison dart frog, curare type medicine so that people aren't moving. Then we give pain control medicine like that fentanyl I mentioned. Then we do give a somewhat lighter dose of medications to block the awareness. And sometimes anesthesiologists guess wrong. And that's why you will hear stories of people who were under anesthesia supposedly, but were aware, awake, feeling pain to some extent, but unable to move because of that paralyzing drug. So it's somewhat of an art, really, to do it right.
Well, they do this when they intubate people as well, because if you're feeling that go down down your throat, it's going to hurt, and you're going to get all these crazy reactions. While I work with paramedics, and so they give these stories all the time. If you don't give the right drugs to kind of knock them out, they're still feeling that stuff. They might not be fully there, but it's just the whole thing kind of falls apart, and then they're guessing, you probably didn't have to deal with this, but the paramedics are guessing weight. They're kind of guessing all of these different things and trying to figure out what drugs to put in there and how much. And so it's it's kind of a guessing game for them.
Well, it's called an art form.
It sounds better. Yeah. It's an art form. Yeah. And it's not bad. I'm not being derogatory. They got to make a decision there. And I think generally speaking, they probably do decent work. But just for the philosophical context for people, these ideas and these words like consciousness that we take for granted as Americans, nobody even knows what that technically means. There's no sort of philosophical or even theological consensus on that. I know that there are theological articulations of what consciousness or the soul, is it the soul or those sorts of things, but those are metaphysical questions. And from what I'm hearing, and I'm interested in what you have to say about this, the doctors that were talking to you, or the authorities that were talking to you, were conflating the physical and the metaphysical in what they were telling you to do.
That's
of course,
correct.
They weren't explaining any of that to you.
Right. No, and interestingly, nobody has ever localized conscious awareness to the brain. That's never been found, never been localized. It remains one of the, mysteries of medicine. To my thinking, our sense of self, our sense of conscious awareness is not a physical attribute. This is an attribute of the metaphysical, as you said, the soul. I think the brain is the organ we use to translate our thoughts, hopes, and desires from our spiritual self into the physical world and allow us to act on the physical world and build and create and do. We are a tight union of the immaterial soul and the physical body. A body-soul unity is how it's usually expressed.
Right. So what did you do after that? Because obviously sounds like you were ignorant to some of these ideas, or what we're talking about even now, the philosophical, theological conversation that is preceding all of this. So what happened?
So, as the case went on then, at one point the surgeon said to me, okay, give him one more big breath and then you can disconnect everything. We're done with you. And, it felt so wrong. I mean, I remember standing there. The surgeon might have had to tell me twice. I don't recall, because I was sort of very confused at this point. I'd never walked out on a patient before. It just seemed like this shouldn't be.
It seemed like the opposite of healthcare.
It's right. But, again, sad to say, my younger self, I did what I was told, and I did. I disconnected and I walked away, and I could see the other people, meanwhile, scrubbing up. The surgeons were in there taking the organs. And then after the organs are removed, after circulation stops, then the tissues are taken. Now, there is a difference between organs and tissues. Organs would be things like heart, lung, liver, kidneys. Those things are very reliant on a continuous flow of oxygenated blood to stay viable enough to be transplanted into someone else. Tissues are things like skin, bone, heart valves, corneas. Those things are much simpler structures, and they can indeed be removed from a biologically dead body and be useful to put into somebody else. So
but organs are not. You cannot remove that from a dead body.
Organs must come from someone who has biological life in their body. Yes, those, sad to say, those come from someone who is biologically alive. Yes.
So after this happened, I mean, what did you do? You're in your residency. Did you start to investigate this?
No, I did. I just thought that was weird, and, and I just jumped back into the fast moving stream that
Really?
is medical training. It was the only harvesting case I did. They usually give those to the junior residents because, what can happen? They're dead already, right? You can't screw it up too bad. As you become a more senior resident, now you become involved in the recipients, and these people with severe organ failure, they're very difficult anesthetics because they're critically ill already. And so that was who I got to work with as I progressed in my training. I always looked at the little picnic coolers they'd bring in with the organs, and I'd kind of wonder, who was that? What was their story? But I didn't really question it until later in life, about 2012, 2013, a science writer.
How much later? I mean, how much time has
This
passed?
was between late 1990s and 2012.
Okay.
Wow. I was busy in my career, my practice, raising a family.
Yeah.
This was an accepted medical practice, and I just didn't give it too much more thought. But it's one of those cases that always stuck with you, right? That was always kind of back there. But in 2012, a science writer named Dick Tracy wrote a book called The Undead. And he went through this whole idea of people who were in a coma being dead enough to become organ donors. And he concluded that, in his book, just from his scientific atheistic perspective, that these people certainly were not dead. And I read that book and it really shook me. And it made me stop and dredge up all my memories from the past. And that's when I started doing my own research. At that time, I had retired because of my husband's brainstem tumor. I had more time. I was less tired. I was less frantic. So I actually went back and I looked at all the original source documents, beginning with the idea of brain death with the SIBA conference and the 1968 Harvard ad hoc committee that redefined comatose people as being brain dead.
Who's comatose people?
People in a deep coma, people who are unresponsive in 1968, were redefined by 13 men at Harvard Medical School as being somehow dead.
Do you know these men? Do you know?
Yes, their meetings have been well researched and documented. This was an interesting time in history. In 1967, Dr. Christian Barnard in South Africa had just performed the first 2 heart transplants. Now, if you think about South Africa in 1968, it wasn't a place of wonderful civil rights,
Sure.
as you might imagine. The first heart transplant donor was a young woman named Denise Darvall, who had been in a car accident. And at the time, Dr. Barnard and his brother Marius told the media that her heart had stopped spontaneously before they took it out and put it into someone else. Later, Marius Barnard actually admitted that they had stopped Denise Darvall's heart with a shot of potassium. The second heart transplant donor was a young Black man named Clive Haupt. He was out picnicking with his family and collapsed. He was brought to Grote Schuur Hospital in Cape Town. And the doctor who was given his care, Dr. Hoffenberg, was approached by the transplant team and said, we'd like you to declare him dead. We have someone who could use his heart. And Dr. Hoffenberg was kind of uncomfortable with declaring a heart-beating man to be dead. And the transplant surgeon actually came up to him and said, God, Bill, what kind of heart are you going to give us? Meaning, if you allowed Clive Haupt's heart to stop beating, of course, it will rapidly degenerate and become unsuitable for transplant. So under pressure, Dr. Hoffenberg wrote later in a scholarly journal, the Journal of the American Medical Association, that he just signed off on it, and they did take that man's beating heart out and put it in another gentleman who then lived for a matter of months thereafter. So this proved that if you had a well-oxygenated, perfused heart, you could have a successful transplant. Whereas before, if you had, in the history of the annals of transplant, if you had taken someone who had biologically died, the organs were not suitable. The outcomes in transplant were not good. So these 13 men then convened a committee at Harvard Medical School in January of 1968, just a month after these South African transplants were done. And they sat down to try to figure out a way, how can we sort of smooth over the idea of using people whose hearts are still beating and their organs are still in good shape for the science of transplant. And so their article came out just months later in August of 1968. It's called A Definition of Irreversible Coma.
That's what the article's called.
It's called A Definition of Irreversible Coma. And if you look at this study, it also is in the Journal of the American Medical Association, they have no scientific references. There were no test studies or evidence that people in a deep coma, which, these people had always previously been considered to be living people. There was no evidence that these people were actually dead. And
can I just say one reason is because that's not a scientific question.
It's not.
So you can't cite science. You can't cite scientists to determine whether somebody's dead. I think that's like the core here.
That's right. So they said the only reason they justified this new idea of saying people in a deep coma might somehow be, dead already was on utilitarian grounds. They said, if we would, by fiat, by the stroke of a pen, redefine comatose people as being dead already, it would have the social utilitarian benefits for society. Number one, of freeing up ICU beds, because, that's a limited resource. And number two, removing the controversy over using comatose people as organ donors. Now, in the draft of their document, just before the one that got published, they had actually said, we need the tissues and organs of the hopelessly comatose in order to salvage those who are still salvageable. Now, an editor edited that out right before they published it because it was a bit too telling, wasn't it? And so in the final draft, it says this will remove the controversy over using comatose people as organ donors.
So there's a lot to discuss here. I think one of the things that's interesting is it seems like the 40s, 50s, 60s post-war consensus is that's the age of like we make boards and boards define everything in boards and the League of Nations that was not the UN, World Economic Forum, the WHO, CDC, like we started to develop these boards, even in academia. You're mentioning these Harvard professors. Why do you think these people, these Harvard professors in this case, were they all Harvard professors or were they
they were some from different places.
Different places, but they convened at Harvard. So why do you think that it was accepted by the culture that random people who have degrees get to decide what life and death is?
It was still an age of great trust in our institutions. It was an age of wonders. I mean, it was the time of the space race. It was the time of the coming up of computers.
Nuclear
bombs, the modern ICU. I mean, the modern ICU was keeping people alive who surely would have died without the technology of ventilators and such. So people were more trusting and they were very excited about the technology.
There's so many places. There's so many different directions I could go. This is just because I've been fascinated with this time frame. So after World War II, we dropped the atomic bomb. I think that there was a God complex that we developed, the West developed. We created a bomb that can wipe out a city in a second, and they created bigger ones after that, ones that could wipe out all of New York City. And through that, these sorts of things began to be accepted. Apparently, random people with degrees can just define what death is, and then we can predicate the whole medical industry on that definition. And then we're all surprised when COVID happens, which is that when I learned this stuff, I'm like, why were we even surprised? This stuff has been happening for decades. So I guess I'm
Well, to sum up what you're saying, I think, brain death has been an idea in search of a justification ever since 1968. So the first justification was utilitarian, free up ICU beds, facilitate organ donation. Then, finally someone did an autopsy study in 1971, 72, where they actually looked at autopsied brains of people who had been declared brain dead to see, are the brains destroyed? No, they're not. Of this autopsy study, 10 of the brains were grossly normal. Less than half, only 40%, showed diffuse destruction. So the author, the principal investigator of that study, Dr. Gaetano Molinari, actually said, is a fatal prognosis enough to declare someone dead? I mean, he realized these people aren't dead. So then this was studied by a presidential commission that was set by President Jimmy Carter. And this commission, the testimony they received, and this was in about 1980, was that these people with a severe brain injury, they were going to die in the usual way anyway, within, probably a week, maybe in children, maybe a few weeks. So since they were going to die anyway, it was no big deal to just, declare them dead a little early and while their organs were still viable.
How did they know they were going to die?
That was the state of medicine at the time. So in medicine, the technology to care for someone with a brain injury hadn't progressed all that far.
Sure.
And so someone with a brain injury, if your brain begins to swell within a rigid skull, it pushes the brain stem down into what's called herniation, down into the spinal canal. And you become very unstable and you do often die if you're not given treatment for that. So it's the state of medicine back then. The problem was that idea that people with a brain death declaration would die quickly anyway was proved to be false. Okay, it turned out not to be true.
Right.
It was what I was told when I questioned it back in the 80s and 90s, right? But it turned out not to be true. Dr. Alan Schumann, who's a pediatric neurologist, emeritus now from UCLA Medical School, he did a literature search in 1998. And he found 175 people who had been declared brain dead enough to be offered the opportunity to become organ donors. But for one reason or another, their families elected to continue their support. And they did not die. One of them, in fact, had lived for nearly 20 years at home on a home ventilator and feeding tube under his mother's care. And Dr. Paul Byrne, who I'm a friend of, thankfully, he's been so kind to help me and shared his information with me. He knew that family and he asked the mother, is he difficult to care for? And she said, no, really, he's very easy to care for. When he would get an infection, sometimes he'd need an antibiotic and then he would settle back down again. So it turned out to be not true that people with a severe brain injury would die quickly. This prompted another presidential council. Okay, so then in 2000 and...
real quick, just before you go into that, I want to hear about that.
Yeah.
The reason I asked that question is because people need to understand that these people are just making godlike assumptions. The only person, and we'll get into the theology of all this in a couple of minutes, but the only being that knows what's going to happen to anybody is God. So anybody who makes those sorts of claims, they're making a godlike claim. They're claiming themselves to be gods. They can know the future and they can know what the outcome is going to be. And I think that should be the paradigm that people are thinking through this with, because I wouldn't feel comfortable saying that I know what's going to happen in like 30 minutes. I think we're going to stop this podcast at some point, but I don't know what's going to happen in 30 minutes. I'm not God. Like, the whole point of being a person is you don't know what the future is, and God's sovereign over the past, the present, and the future. And so the idea that somebody in the medical industry or in any industry has the confidence to make a statement that has the implications like that are predictive of the future, that tells me one thing, and that's that person thinks that they're a god.
Well, and think about historically. Historically, you didn't need a doctor to tell you when someone had died. Right? People were recognizing death, at home, on the farm, on the battlefield for thousands of years. And in those times, it was very critical to be sure the patient had in fact died. You remember the old 1800s safety coffins, right? Where they had a bell rope attached to the coffin in case they had been declared dead too quickly.
I want them to do that for me, just because I'm always afraid of that.
So historically, people would recognize death by the absence of a heartbeat, the absence of breathing, and critically, the passage of time to be sure that these functions would not return.
Essentially, God himself confirms it
That's
through the
right.
passage of time.
And that's only because we cannot see the immaterial depart. I mean, death at a spiritual level would be the separation of our immaterial from our material, of our soul, spirit, life force, however people want to refer to it, from the material body. But, again, because we don't have a soulometer, we can't,
Right.
can't see that departing. We recognize death by these physical signs, loss of heartbeat, breathing, and the passage of time, so that we know it's not going to return. And these lead to our traditions, the wake, the visitation, the vigil, time for grieving, important, also time to be sure that death has actually occurred.
Yeah, the liturgy of death, essentially.
That's right. But now with the advent of transplant, the shift has been to declare death as quickly as possible for the sake of those viable organs.
So what was the next?
So because it was found to be, Dr. Alan Schumann disproved that people died quickly after a brain injury. Another presidential council was set, and these doctors accepted Dr. Schumann's work. They said, yes, Dr. Schumann has proved that this was false. And, they basically said all of the death declarations we've made up till now were made on a faulty premise.
How many do you know?
Between, 1968 and 2008?
So millions?
Thousands
Okay.
for sure.
Thousands.
So then they sat down, they tried to decide, well, either we have to give up on this idea of brain death, or we have to come up with a new justification. And we all know they came up with a new justification. They said, without giving really any reason, that people who were unresponsive and unable to breathe on their own are so disabled that we could classify them as being dead. So now that justification.
What does unresponsive mean?
When I poke you, you don't move.
Okay, so it's still very physical.
Yes,
okay,
right. Yeah,
gotcha.
we think we can't judge consciousness as doctors.
Yeah.
But we can judge that you're not responding. So again, that justification is based on sort of a faulty philosophy of disability. People who are incredibly disabled could be as good as dead. And then, before the show, I was talking to you about Dr. David Magnus, and he just gave a lecture this spring online that people can see. Dr. Magnus is the co-chair of the ethics department at Stanford. He's the editor-in-chief of the American Journal of Bioethics. I mean, this is the person teaching our bioethicists today. In his lecture, he said, I think we've been taking the wrong view. And he actually had a slide. He said, this is the wrong view. What people have always thought is that we should have a philosophical idea of what death is, and then that should drive what the law is, and then that should drive clinical practice, what doctors and nurses do on the field.
In other words, logic.
Well, that's how we've looked at it so far. But Professor Magnus says, no, that's actually the wrong view. What he says is the correct view. And he referenced the Harvard 1968 ad hoc committee as having this view too. He says, what we should do instead is we should have clinical practice what we want to do, right? Yeah. That should drive what the law is. And then philosophers can argue about it later.
So the Soviets and the Nazis, essentially.
We can do what we want if we have the power to do it, and that should drive the law. And then the philosophers can, it makes philosophy into sort of a word game, right? It's crazy, but that's what the people in the ivory tower in bioethics are teaching right now.
And that's just like, so people know, that's like where the textbooks and where the education comes from, and where that in and of itself is a philosophical statement anyways. So it contradicts itself too. So it's kind of a joke in that sense, but that's top down.
Utilitarian bioethics, completely.
So when you're researching all of this stuff, I'm sure you came to a central question. And I think this is a central question of all of this is like, what is death? What does it mean to die? And how do you know if somebody's dead? First question, what is death?
As Christians, we have chapter and verse for this, right? Mm-hmm. So in James, it says the body without the spirit is dead. That would be our definition of death.
Great. We should just put that on the wall in every hospital in America.
That's right. And again, ecumenical councils have ratified this decision. In 1311, the Ecumenical Council of Vienne said that the soul is what was called the form, or the principle of life and being of the body. So as long as there are still signs of life, vital signs, vital coming from the Latin vitalis, of or pertaining to life, as long as there are still signs of life, we must conclude that the soul is still united to the physical body.
Did you ever read the original Hippocratic Oath?
I was never required to say that because I went to school in Madison. In Madison, I graduated from medical school in, what was it now, in 1988. They were pro-abortion, and the Hippocratic Oath, of course, says you can't do that. So
they changed it.
They gave us some silly thing to say how we would just promise to do what was right in our own eyes or something like that. I can't remember what they said.
But the original Hippocratic Oath from thousands of years ago, it makes the doctor, whoever, the physician, basically make a vow. They make a vow to not kill somebody, even if it's what they want, even if they're asking to be killed, even if they want to be put out of their misery, because it's not our job as human beings to define and to decide when somebody dies. That's God's job.
And it erodes trust in your doctor.
Yeah.
Right? And that's the problem we have now. I mean, doctors,
but they changed that.
Doctors now have divided loyalties, especially when it comes to transplant. I mean, yes, I'm supposed to care for my patient here, but I'm also supposed to have an eye for those organs for the good of society. And so doctors' loyalties are conflicted.
Right. And my understanding is that was the age-old Hippocratic Oath. In the 1960s, maybe a little bit before that, they literally took that line out. And now even the Hippocratic Oath that people still, if any hospitals still do, apparently Madison doesn't do that anymore, which is not surprising to me at all. But any other hospitals that still do it, they've changed all of the definitions and they've changed the Hippocratic Oath. So it doesn't even make you make the vow to not kill somebody, which is sort of strange to call yourself healthcare when you refuse to vow to not kill people. That's like the opposite of healthcare. So I do want to get into the theological conversation. Obviously, you said in James, there's a very clear definition when the spirit or soul leaves the body. There's a lot of questions surrounding that. So what exactly is the soul from the Christian perspective, or the spirit? Like, what does that actually mean? It's a difficult question because theologians have been arguing about this for a long time.
And we're not going to settle it today.
Right.
But, it does say, that, God formed Adam from the dust of the earth and breathed into him the breath of life. Okay. It doesn't say God formed Adam from the dust of the earth and gave him a brain and he had life, right? Mm-hmm. It's a very materialist idea to think that we're our brains. Right, we are not our brains. Right. We are that body-soul unity.
If you eat from the tree of the knowledge of good and evil, your brain will surely die. That's not what he said.
Yes. Yeah. Yes.
So go ahead. So the breath of life comes into man, and when that leaves, and the reality here is we don't know when that leaves. So time is the only, like you said earlier, time is the only way to verify that. At what point did we stop taking the Christian? Was it the 1960s? Was that when we were like, okay, we're done with the whole idea of the soul leaving the body? There's financial incentive to get rid of that, and we can make money off of organ harvesting. Was that when it happened? Was it prior to that? Was it the 1800s or the Industrial Revolution? Like, do you know when this sort of train of thought started to tyrannize the medical industry in the West?
I think there have been bad apples all through history, mm-hmm. right? I think as a general cultural idea, I think it was the 1968 Harvard ad hoc community that mm-hmm. actually pushed this into the idea of brain death. And then in 1990, a second pathway to becoming an organ donor arose. And most people aren't aware of this. In the 1990s, always trying to expand that donor pool, donation after controlled circulatory death became a thing. And so what this is, these people are not brain dead, but they have a poor prognosis, right? And they're not expected to have a good potential for long-term health or recovery. And so it's actually a lower bar to becoming an organ donor than brain death. With brain death, you have to, pass a series of tests. With this one, you just have to have a poor prognosis. People with a poor prognosis are then approached by organ procurement. There's actually administrative law that everyone who might potentially become an organ donor. There's a specific HIPAA carve out. Their medical records and everything is transferred over to people in the organ procurement industry. And then they approach the family and they say, your loved one, is just not doing well. And they wouldn't want to live this way. And, maybe you could make something good come out of this tragedy by making them an organ donor. And so
that's like demonic. I'm sorry. That's like that. The way that you're even, and I've been around the medical industry my whole life. My mom has worked in it. I work in the medical industry. That is exactly how people talk. And again, that's like the only way that you could talk that way is if you believe that you're the arbiter of reality. I could never say that to somebody. I don't even know how you could allow for those words to come out of your mouth. The only way for good to come out of this is if you let us kill the person, carve them up, and then send their organs out and make a bunch of money off of it. That just seems a little bit off. I don't know.
Well, but they're not straight with the people. So
Right.
They say what we're going to do is we'll give your loved one a do not resuscitate order, right? Because all of these people could be resuscitated, but a decision has been made not to do so, right? So these people's deaths are a choice. So interestingly, these deaths really similar to brain death. These controlled donation after circulatory death determinations do not adhere to our U.S. law. The U.S. law for circulatory death requires the irreversible cessation of circulatory and respiratory functions. These people, it could be reversed, right? But now you've given a DNR order, so it will not be reversed. Doctors say it's permanent is the wiggle word they use to get it. This person's loss of function is permanent because it's not irreversible. Irreversible means unable to be reversed. Permanent means we're not going to reverse it, right? So then these people are taken to the operating room and their ventilators and their drips and their support are withdrawn. And then the person, to be able to give viable organs, has to become pulseless within 2 hours at the outset. Some hospitals go with 60 minutes or 90 minutes. 2 hours is about the longest I've heard. So this person kind of quietly gasps their life away. Sometimes they're given some sedation to facilitate that, to be more comfortable during that process. And then once their heart stops, once they become pulseless, doctors observe a 2 to 5 minute standoff period to be sure there's no spontaneous return of circulation. And at that point, surgery it starts as quickly as possible because time is ticking and those organs are not being perfused. You need to get them out as quickly as possible. The problem is everyone knows that people are routinely resuscitated after just 2 to 5 minutes of pulselessness, right? You teach CPR, you know this. And if you could still be resuscitated, you were never dead. I mean, I am not a resurrectionist. I am a resuscitation and a resurrection are two different things.
100%. Yeah.
To be able to resuscitate someone, they still have to have life in their body. Their soul, their spirit is still in conjunction there. I mean, resurrection, you have to have a divine intervention for someone to truly come back from the dead, right? So these donors after circulatory...
Jesus wasn't resuscitated.
That's exactly right. Lazarus too, right? Yeah. So these people are being gulled, honestly, when they are approached about this. They're like, we'll let their heart stop and then they'll be dead and then we'll take their organs out. So people are being deceived about this process when they sign the consent. I mean, the lack of informed consent on all of this is staggering.
It is
and
staggering.
that's why some of these DC donors have actually self-resuscitated on the operating room table. So last year, actually, I love being able to cite the New York Times. The New York Times had a wonderful article about DCD donors, and they had case examples. The most heartbreaking one to me was the case of Misty Hawkins. Now, Misty was a vulnerable adult, a young woman living at home with her parents. She was eating her lunch and choked on her sandwich. She was brought to the hospital and had a low oxygen and anoxic brain injury. She was not brain dead, but the doctors told Misty's parents that they didn't expect her to get off the ventilator, and she was given the opportunity to become a DCD organ donor. Now, Misty's parents, they don't want their daughter to suffer, and they're told, here's a way of bringing something good out of this tragedy. So they agreed. So Misty was taken to the operating room and her ventilator and support was withdrawn. She It took her, I want to say, like 103 minutes to become pulseless. Doctors then gave her 5 minutes to be sure that she wasn't resuming a heartbeat, and then they started in operating. But what happened was when they sawed open Misty's breastbone, they found her heart was beating. It had started beating again, and she was gasping for breath. Now, there's a protocol for this because this actually does happen. So at this point, the protocol is the transplant team has to leave the room. They found another doctor to stitch her back up. If I recall right, it was about 12 minutes for her to become pulseless a second time. It's not clear that she received any anesthesia during this interval. And what's really horrifying is her parents were never told. So the organ procurement coordinator calls Misty's mom and says, gee, I'm really sorry. It just didn't work out for Misty to become an organ donor. So her parents learned the facts about this when the New York Times reporter approached them for comment.
Seriously?
That's how they learned what happened. I mean, as a mother, I can't even imagine.
I think that would turn somebody into a radicalized person, and they would start thinking things that people shouldn't be thinking.
Yeah.
But it makes perfect sense.
Yeah. No, this happened just in Illinois, too. I have a case report about a young woman who was a DCD donor in Illinois. They were just going to take her kidneys. As they cut down to her kidneys, they see suddenly she's got pulses in her aorta and renal arteries, and she starts breathing again. The county coroner in that case determined that woman's death to be a homicide, straight up homicide.
Real quick. Quality of life, because that's like a phrase that people use all the time. I think that's sort of embedded into what you're saying. There's an argument of, the quality of life isn't going to be good. You don't want the person to suffer. That's what you said. I don't agree with that at all. The idea that we don't want people to suffer, that's just a really modern idea. And also the idea that the medical industry isn't supposed to mitigate suffering full on, right? Because if that were the case, we'd have to kill everybody because everybody suffers. So that's not the job of the medical industry. 2, suffering, I have not heard a legitimate argument for why it's inherently bad. Suffering from a biblical perspective is good. Jesus' entire life was full of suffering, and the job of suffering is to strengthen and to make you into a better person John Calvin suffered medically his entire life. And he had horrible medical problems, and he wrote some of the greatest theology in human history. So why is there an assumption in our culture that suffering is bad and that the medical job is to get rid of it? You realize you're asking a pain
management physician this question?
No, sorry.
Okay. No, I certainly, I'm not saying that suffering can't have redeeming value. It can, but honestly, we all need to try to love one another in a way that helps decrease their suffering, physical, mental, spiritual, as much as we can. That's an honorable and noble goal.
Do you think that's true?
Oh, yeah.
I don't think that's true.
I think if you're hungry, I'm going to feed you.
That might be, if you should give me food. But for instance, biblically, in the New Testament, when the apostles go out to spread the gospel, and that's our call, to go out to spread the gospel, Jesus literally tells them, you're going to be killed for this. So if you take that logic too far, then all the pragmatic Christians in America don't go out and spread the gospel. If you're going to be killed for it, we got to stop that.
Pain avoidance is not the same thing as mitigating suffering, though. I mean, you have to go out and you have to honor your commitments. You have to honor God, whether that costs you your life. People who are missionaries on the foreign field, they understand they're going into that battlefield and they accept that risk.
Do you think
but
people
when
are
your
making
child
those distinctions?
Skins his knee, you're going to wash it up, give him kisses, and put a Band-Aid on it. I mean, it's all right to do that. And so,
right, but I'm not going to wrap him in bubble wrap for the rest of his life like modern parents do. But I'm not trying to be too contrarian in this, but I think the idea that we need to mitigate suffering, I just don't see that. Like, I don't see that. I know you're a pain. I didn't even think about that when I asked the question.
But use good judgment.
Yeah, and I think that's not happening at all. I think that the obsession in the American imaginary is to mitigate suffering in every way, shape, and form. And I think that the medical industry has basically just manipulated people into being obsessed with, like, you got people who were during COVID wearing big bubbles around them Like it's like I don't even know how to articulate how crazy it is. And that all the preceding philosophy that builds to that is suffering is bad and pain is bad. And from the Christian perspective, that was never, ever the case. That's why we came to America. That's why we came in the Mayflower. And when we like landed in Plymouth, half those people died, but they knew that what they were dying for and what they were building and the pain and the suffering that they were actively, willingly enduring could potentially, they didn't know what it would become, could potentially create something greater and better. And I talk to people all the time from all over the country, people my age, people older, people, nobody thinks that way anymore. And I think that the medical industry is like the industry that has basically propagandized everybody into believing that suffering and pain is bad and wrong and evil, full stop. And I know you're not saying that, but I think we need a more robust conversation around like you mentioned, the lady said that she cares for her son or daughter, I can't remember, but at her house, and that, it's not the most difficult thing ever, but that person obviously is suffering. But there's something that's good that's coming out of that. She is serving him. She's playing the role of Christ in his life and serving him and doing that for a long period of time. Like that's a good thing. And the medical industry, like you've mentioned throughout this, their response to that is we'll just kill him and then we'll help everybody else. I'm saying that in air quotes. So sorry for the rant, but
let me take this in kind of an interesting direction that I think will help people. So as far as when someone is very ill, right? Mm-hmm. Bioethics has kind of divided the philosophy of how we care for that person into ordinary means and extraordinary means. Mm. Okay, so when someone is ill, ordinary means would be things like food, air, and water. We don't put a pillow over their face. We don't dehydrate them to death. We don't starve them to death. Like we were talking about the case of Terry Schiavo earlier, a young woman with a persistent vegetative state. Her husband got a court order to remove her feeding tube and let her slowly starve and dehydrate to death. That would be considered wrong. Extraordinary means would be things like ventilators, ECMO, this type of thing. Those are considered to be morally optional. Okay. And I run into a lot of people who suffer a lot of unnecessary guilt. Grandma was at the end of life on a ventilator and the decision was made to withdraw the ventilator and allow grandma to go into an eternity, right? That is morally okay. I mean, none of us are getting out of here alive. And
you're making the argument that
yes.
I don't think that's morally okay at all. You do not need to continue extraordinary means.
Where
are you getting that from? Where's that? Like, that's not a biblical concept at all.
Take grandma or grandpa in your arms, hold them, pray over them, sing to them, allow them to go to the Lord. Let the underlying disease process is what takes their life, right? That's what takes their life in the end.
I just don't see, I understand the logic. I don't see the ethical declaration. Like, I don't think that that's as clear cut as what you're saying. The idea that makes me like, okay, so that's something that I've thought about because obviously I have old people in my family. And at some point these questions will start to come up, and I don't see any ethical, biblical, theological reasoning for if you have the means necessary to keep a person alive, why you wouldn't do that.
No, again, people on the end of life, on a ventilator, if they want to go home to be with the Lord, I think it is morally, ethically all right to withdraw extraordinary means and allow the underlying disease process to usher them into eternity.
Do you think that that's not suicide?
No, that's not
Why?
suicide. That's accepting the inevitable. Accepting the inevitable.
If I committed suicide tomorrow, I could accept the inevitable that I'm going to die anyways.
Taking an active measure is not the same as removing extraordinary levels of support.
All right, we're not going to agree on that, but
we'll
move past that.
We can disagree on that.
I do want to talk about T.J. Hoover and Network for Hope, because this is a recent thing directly related to what we've been talking about throughout this entire conversation, and a proof for why a lot of what the medical industry is doing is just wrong. And so explain or tell us about T.J. Hoover and that story, Network of Hope. And then I actually want to hear about, I know Kennedy is involved in this and some of the recent things that have happened.
No,
so go ahead.
I'll start with what happened
Yes.
to TJ himself. So TJ in 2021 was a young man, unfortunately, suffered a drug overdose, was taken to the hospital in Kentucky. He was someone that had a poor prognosis, and the family was planning to simply remove his care and let him go. But because TJ was a registered organ donor, the family's hands are then tied by that. And again, people, when they sign up as an organ donor, are never told, once you've signed a registration to become an organ donor, that is considered legally binding. Your family, your healthcare surrogate will not be able to stop organ procurement from proceeding. Important for people to know, because a lot of families think that that's a choice, that they'll be able to say, no, we don't want that done. No, once the person has signed a registration, that is a legally binding document.
At 16, they usually do that.
Right. But once you become, of age, then it's binding. I think.
Have you do that on your driver's license or something?
Yeah, it's on the driver's license. And so actually organ procurement organizations have successfully taken families to court who contested this and have successfully sued to remove organs over the objections of surviving family, because it is legally binding. So TJ's family didn't have a choice. So organ procurement comes in. Because TJ had I think he had some cardiac arrest as part of his drug overdose. They weren't sure if his heart was in good enough shape to put into someone else. So also once you're on that organ donor path, now tests begin to be performed, not for your benefit, but for the benefit of your organs. So TJ was taken to the cardiac cath lab to have a cardiac cath to evaluate whether his heart damage had been sufficient enough to preclude heart donation or not. While he was on the cath lab table, he started to grab the doctor's hands. He started to be moving so much they couldn't do the test, so they had to give him rocuronium, a paralyzing drug, to keep him from moving on the table. So that's sort of a red flag. If I'm grabbing your hands when you're doing my cardiac cath, that's a red flag. But it didn't stop anybody. So then on his honor walk on the way to the operating room, I have a friend who calls it the horror walk, which kind of it is. But during his honor walk, he started looking around. He started tracking, and he makes eye contact with his sister, Donna Rohrer. And Donna says, look, my brother's looking at me. And the organ procurement team says, oh, no, those are just reflexes. Right.
What are reflexes, real quick?
Well, reflexes are a pretty stretchy term in the organ procurement industry. There are many things that people are allowed to do and have these called reflexes. Some of them are actually fairly laughable. I mean, the one, as a CPR instructor, the universal sign for choking when you reach, that's considered a reflex. It's hard to tell, is that a reflex or a volitional movement? But they will categorize it as a reflex. If you lift a limb off the bed, that's considered a reflex. My favorite one, because it's so bizarre, they say if you brush the patient's nipples and they open their eyes, that's a reflex.
Really?
I know. The reflex term is pretty stretchy in organ procurement.
But doesn't that require, at the very least, a reflex requires there to be some sort of energy?
Well, you're biologically alive, right?
Yeah.
Dead corpses are cold, dead, and stiff. They don't move, right?
I've never been to a funeral where you see reflexes.
You better not. You better not see that. So anyway, they took him into the operating room, but the staff, even in the operating room, were very uncomfortable with TJ Hoover because he was thrashing around, he was looking around, and then he started crying. Right. So the organ procurement coordinator, the doctors refused to proceed. Called her supervisor back at the home office and said, "Look, this just isn't going well." And I'm sad to say it, but the supervisor said, "Look, we're going to do this case or you're going to lose your job. Get another doctor."
Was a supervisor a doctor
or
was this just a mid-level manager?
Someone off-site that wasn't there in the room. Thankfully, another doctor could not be found. And Mr. Hoover did recover, and was able to leave the hospital. His sister was told, just go home and make him comfortable. Here we are 5 years later. He's still alive. You can see pictures. He was able to dance when his sister got married at her wedding. I mean, he does require care. He has a brain injury, but he does remember what happened to him. I mean, he still asks his sister, why did they try to kill me? So because of this,
So he knew. I mean, so that tells you he was hearing and understanding.
He was aware of what was happening. So this has led to a couple of things. The first thing is in July, just last month, Kentucky actually passed a new law that allows any whistleblower to pause an organ procurement if there are signs of life. Which is
how do they define signs of life?
Well, they actually break it down, and it's quite nice, because this is going to allow challenges, particularly to a diagnosis of brain death made under the American Academy of Neurology brain death guideline. Because let's face it, all brain dead people show signs of life, right? They have beating hearts, they have temperature, they have, blood pressure, they have signs of life. Another sign of life is reaction to pain. Well, it's routine, that we give anesthesia to these people because their blood pressure and heart rate respond to incision, which is a sign of pain.
As you're talking, I'm just thinking, there's always sort of a mystery around in the Old Testament, in the Bible, why blood, and in the New Testament, of course, the blood of Christ. Why is blood so important? Why is that important? And I don't, as you're talking, this is sort of just like off the cuff, I guess, but like pumping blood in and of itself, if it's happening without external, people doing compressions or whatever, that seems to be like a clear sign of life, right?
And
blood
Thomas,
represents
if you read
that.
Aquinas, this is
right.
The internal motion of the body is the motion of the heart, the motion of the blood was what forms the hylomorphism, hylomorphic theory.
That's why a blood of the lamb. That's why like the blood needed to be spilt, because that's a sign, a symbol, or a sign, or a metaphysical, physical reality of life. And so that's interesting.
Because of the motion.
So even taking it from the blood and then getting rid of that whole concept and just saying it's brain activity or whatever they're saying about the brain, like that's a clear. They're just ripping these things apart from each other, basically saying blood doesn't matter anymore. We found a new part of the body that is incredibly mysterious, that people don't understand, that we can sort of impose our philosophical definitions upon and then create an entire definition of death. I mean, that's basically what they did. So, because blood was the primary.
Well, it was. And I often ask people with a pro-life ethic, here we are, advocating for the rights of the unborn. That single cell, when an egg has just met sperm, there's no brain, there's no blood, there's no heart.
Right.
This is a fully human person. So it's really inconsistent at the end of life that we take someone whose brain simply isn't working very well and accept that they're somehow dead. Utilitarian philosopher Dr. Peter Singer has actually written a paper chastising pro-life people about this, saying, this is very inconsistent. And he can see it and point it out. Now, Peter Singer himself is willing to admit that brain death is not the death of the human person. He calls brain death an ethical choice masquerading as a medical fact.
What does he think death
But
is? Because
he's a utilitarian, he says that these people who don't have good cognition, their life is of no value to them. And because utility means the most good for the most people, he would justify taking that person's organs because their life is not as valuable as those organs might be for society.
Do you know how he defines good? Most good for the most people? Do you know?
I think that's the utilitarian way of doing it.
But I'm wondering how he defines that even. Because like we talked about earlier, taking care of somebody who can't take care of themselves provides a good for the person serving for them. So how do they...
what standard and who gets to decide?
Yeah, that's kind of the question.
Who gets to decide what's the most good?
Peter Singer gets to decide, right?
My personal peace and prosperity trumps your whatever you want, right? And that's the problem.
So what happened with Kennedy? I saw some of the news. Yeah.
Back to that. So thankfully we do have this new law in Kentucky. And I was speaking in Kentucky just last weekend saying, you need to use your law. You need to make legal challenges at this point, which is wonderful. All our states should have this. So what happened just on August 5th, a few days ago, is RFK Jr. And our Health and Human Services Department have come out and decertified the organ procurement organization that was working with T.J. Hoover. It was called Kentucky Organ Donor Affiliates. It rebranded itself as Network for Hope. And, the problem that...
That's a terrible name.
They're all very evocative names. But I was able to personally speak to a whistleblower who worked in that Network for Hope. And she described to me the debrief that they had after the TJ Hoover case. And she said, you know what? Management just shut us down. They said, we did everything right. We did everything by the book. We do it just the same again. And that was, I think, the attitude that RFK Jr. in his press release came out with, saying that they had looked at this organ procurement company, they'd found lots of infractions, and they had found a unwillingness to change. And so
that's purely ideological too. That's like how ideologically captured unintelligent people speak.
That's right. Oh, well, and it's also, cover your butt because you don't want to get sued.
Right. That's the other part of it too. Right. Yeah.
So what happens now is they have until November 3rd to appeal the ruling. From what I understand, Network for Hope is planning to appeal. Failing that appeal, November 3rd, that district will be opened up for competitive bidding by other OPOs to take over that district. So again, it's not going to change anything in a big way. And so what I tell people is, unlike so many problems in our society where the ordinary person really can't do much about it, in the organ transplant industry, there actually is something you can do. And my recommendation is that no one should be a registered organ donor. It simply is not ethical or safe at this point.
It definitely shouldn't be the assumed.
That's right.
So the other thing that I think people can do is the church can begin to speak about these things again.
Oh, yeah.
Because the church isn't doing anything about anything. They won't speak about abortion. They won't speak about transgenderism. They won't speak about homosexuality. The church has basically abandoned its position as the conscience of the state. That's Bonhoeffer's terminology, not my own, but I think it's true. For all Bonhoeffer's weird theology, he got that right. And so I think the church being adamant about what death is and who defines death is really at the center of all of this, the only mitigation against this thing happening more, because the idea that the state can define these things is obviously not true. But I also think that, I had a train of thought, I just lost it. But anyways, the church being the ones who define what death is, I think is really the only way that you can fight against it. So here's what I'm going to say. The legal reality of this, all of this stuff, I kind of think Christians and conservatives can get caught up in the legal battles. And then it becomes sort of like splitting hairs and trying to argue over what this terminology means and what this means. And that's sort of what America has become. It used to be a place where there was not as many laws. Now there's laws for everything. I've probably broken like 400 laws just getting here today. And that's because we are a society without personal virtue. You don't need a bunch of laws when you have people who impose a law upon themselves that comes from a higher governor, which is not the state, which is God. And so that to me isn't being taught in the churches, as the ones that I've gone to. Do you think we're in a church right now? Like, do you think that the only place, the only people, the only book that has the authority over this is one, the church? They have the authority, but the church under the authority of the Bible and God. Is that what you would say?
I think we've done a very poor job of instructing people what is in the Bible, what do we believe, what should we believe, and why? And this needs to change. And I'm thankful that there are some pastors now.
Yes.
Pastor Jeff Pollard wrote the foreword to one of my books. Pastor Curtis Knapp just sent me some sermons that he preached to his congregation, helping them to better understand, end of life issues. I mean, so it is changing. And our pastor here has allowed, me to have a forum to speak to our own congregation. And so I think it is changing. The pro-life organizations are also becoming aware of this. I've just had the opportunity. I was able to speak at Georgia Right to Life, at Texas Right to Life, for people at the Kentucky Doctors for Life. This is something people are beginning to wake up to, and I'm glad for that. I think that's a wonderful thing.
Yes, I think that that's true, and I think that there are younger people because of COVID and what happened during COVID. Not just younger people, but everybody sort of was like, "Whoa." The medical, obviously Fauci, I don't know if you read his diaries or whatever, but there is a God complex among the people in the medical industry. It's not just medical. I think it's the academia. I think it's all different industry. I think it's the church too itself, certain aspects of the church, but there's a God complex. We define reality, we enforce reality, and we can determine outcomes. And those things are for God. And I think that COVID exposed that. And a lot of people right now are much more willing than they were 10 years ago to being like, hold on, brain death? Like what do you mean brain death? You know? And I think I think you're right. That's good, but it would have been nice if, especially the Protestant church, had built up a robust theology of these things over the past 100 years to have the infrastructure necessary for now the fallout of the medical industry. And I don't think we don't seem to have the infrastructure set up for that. And so I am a little bit nervous. I'm probably a little bit more skeptical or pessimistic about it because I've seen a lot of the churches in my city in Madison, Wisconsin, double down on the medical. Mary Talley Bowden calls them the medical mafia, their doctrines and their ways of doing things. And so I'm not sure where this is going to go, but all of that is to say, I guess final question would just be that practically speaking, and I know you said this, about organ donation and things like that. What can Americans do to avoid this, like practically, specifically speaking?
Yeah, this is a great question. I was just telling your wife about this before we started. The whole idea of transplant is sort of built on the lifeboat ethic. Okay. So if you think about, back in the Titanic or other maritime disasters, you have the people in the big old leaky lifeboat, very little fresh water, very little food, overloaded. Because of the scarcity of resources, it justifies moral atrocities, taking the weak, throwing them overboard, right? That's the thing. And that's what the transplant issue has done. They've set up sort of a lifeboat analogy. They're like, we have all these people who need organs. There's a limited supply. So it justifies the moral atrocity of using people who are still biologically alive as organ donors.
Can you, real quick, I'm so glad that you brought this up. Can you talk about what's happening in China? Because I totally forgot
I'll get back to China.
Okay,
Let me finish up here.
Sorry. Yeah,
that's all right. So, but the problem is, the unanswered underlying question is, why don't we just build more lifeboats? I mean, really, why are we talking about, why do we just have one leaky lifeboat that we have to throw people out of? Same thing in transplant. We can just build some more lifeboats. And there are things that we could be doing. So one, artificial organs. In Australia right now, they just discharged their first patient from the hospital, the Bivacor artificial titanium heart. Charge it at home like a cell phone.
Does it work?
It's working. And they're using it as a bridge to transplant. But ultimately, can you imagine how great it would be to have product on the shelf? You have a heart failure patient, put it in him. No waiting, no immunosuppression. Right now, they have to charge it every 4 hours with a cable, but they're going to do it. They're going to do it with an induction, just like a cell phone induction charge.
Really?
Yeah. Wonderful thing. Second,
there's nothing that can be that's not being controlled though by anybody. So like they can't turn it off if they want. So the medical. Okay.
No, this is an individual thing. Second new lifeboat we could have. Living transplant. I mean, you and I both know a family where the mother donated a kidney to her young daughter, who's now lived nearly 30 years. Mm-hmm. Living donation, in which both the donor and the recipient remain alive after the procedure. Totally wonderful, ethical.
Especially if it's interpersonal.
Oh, yeah. Terrific thing to do. Now, if you think about it, brain death, it's about less than 1% of U.S. deaths nationwide, whereas the potential number of living donors, it's vast, right? And you can give almost any organ except the heart with a living donation. I mean, the kidney, you can give a lobe of your liver. They can actually do lung transplants this way. They take one lobe from each of two donors. You can do a lot with living donation, and that's an ethical lifeboat we could be offering to these people. If I think it would be important. Could we subsidize this to make it easier for people to want to do that kind of thing? Could we make their time away from work covered or something? Okay. The third thing, of course, is could we just work on making people a little bit healthier so that they don't get organ failure in the first place? So I think building more lifeboats is a way smarter thing than continuing to justify moral atrocities because of this false idea of scarcity.
Right.
Yeah.
Well, I think I just saw a chart that showed that obesity rates are going down for the first time in decades. So that's a great thing. And again, I think COVID was a wake up call for people there too, because it's like if you're fat and out of shape, you're going to die quickly. That's just in general, that's the case. But if you get a sickness, I mean, there's underlying symptoms there. So I
Should
know.
we talk about China?
I do want to talk
Okay.
about that because we were reading that on the way here. Andrea was reading that portion of the book to me, and I think I'm going to try to be quiet because this is like enrages me beyond comprehension. But can you
All right,
speak
let me
about
tell you.
that?
Let me tell you the horrors. So this is the horror. So if people are readers, Yanya Keelik has just written a book. Ethan Gutman has just written a book about in China. It is well documented that the Chinese Communist Party for many years has been using prisoners of conscience as forced organ donors. And so what happens is, it was mostly Falun Gong practitioners, Falun Gong being sort of a meditation and exercise, semi-Buddhist kind of a philosophy. It was a real challenge to the Chinese Communist Party because these people's values include being ethical and honest, compassionate and truthful, which that doesn't work to keep up a communist regime, right? So they began, persecuting these people, incarcerating these people, and looking for ways to get rid of them. And it was almost in a funny way for a communist state. It was almost sort of a free market idea. Find ways to get rid of these people, and if you can make money at it, even better. Mm-hmm. So this is what happened. They started to advertise. You can get your organ in China scheduled on the date you come, and it'll be for a lot less money than you're going to pay in the West. So how this got exposed is an Israeli surgeon, a patient came in for a pre-op physical saying, I'm going to go to China and I'm going to have a heart transplant on, whatever day it was, May 21st. And the guy says, well, how can you schedule a heart transplant? How do you know that someone that is your match will be available on that date to die? Well, it turns out they absolutely know because you've done all the matching ahead of time. They've got a prisoner that is your match, and that person will be taken down to the operating room and executed via harvesting on the date all the transplant tourists come to get their organ. And that's been going on for a long time, and it's very well documented. Doctors Against Forced Organ Harvesting are right now petitioning the G7 to get people to not participate, to make laws that no one going to China will have their operation covered. Already Israel has passed a law saying that we will not pay insurance money for any organ received in China, but in America you can still get insurance coverage for those organs.
I think there's many different things here. One is it's been sort of a conservative trope to just go after everybody who is skeptical of laissez-faire free market capitalism. One, because it doesn't exist, because we have a massive government and they subsidize things, whatever. But two, because if there's no regulations on capitalists, they still have human nature and they still are sinful and they're still going to do things like what you're describing right now. And the government's job, biblically speaking, is to withhold evil. So there should be some sort of government intervention in that case. In this case, it's obvious. You shouldn't be able to, I think you mentioned in your book, it's similar to prostitution from the biblical perspective, just selling your body parts off. Like that's literally prostitution. That's for sexual pleasure. This is for other things, but the same principle is there. So that's the first thing. Like, I think people need to be thinking more sophisticated about economics, because the economics have real life implications on people, and not just in America. Even we know that our iPhones are created in China by people who they have to put nets up on the buildings so they don't kill themselves because of the situation that they're in. And so that's important, but also what happens when you take somebody else's organs and you put it into a different person's body? We didn't even talk about this, but are there negative effects that has? Like I can imagine people are different. They have different biologies. Obviously we're not fundamentally different, but like, how does the body reject that, or how does that work? And then how do you mitigate the rejection if it does?
Right. So yes, your body does reject anything that is recognized as being non-self. And so this was a big hindrance to transplantation in the early days until the immunosuppressing drugs were invented. So if you receive a transplanted organ from someone else, you are for the rest of your life going to need to be on immunosuppressant medication. And that means that you are more able to get cancers and infections and things. It's
Really?
Oh yeah, your immune surveillance is diminished, and that does have long-term health problems.
How does your body know that it's non-self?
It's an amazing system of the way your body recognizes your own cell structures and your complement and your antigens are different than anybody else. It's your immune system.
That's interesting. I didn't know that.
Yeah.
Well, there's a lot more we could talk about here, but I think that that's a good, for somebody who hasn't heard any of this stuff before, it's probably overwhelming. It was overwhelming for me. There's one more thing to talk about quickly. My wife just mentioned it to me, abortion. I do want to just talk about how this relates to abortion, just even for a couple of minutes, because abortion is the greatest evil that any society has ever conducted. And in America, we've killed 60 million babies. And I'm wondering, is there a connection between organ harvesting and abortion?
Well, it's, the loss of respect for human life at both ends of the spectrum, right? And, David Daleiden certainly exposed how the abortion industry is using those poor little babies for parts, for organs, for research purposes and that sort of thing. So yes, there is a connection. So
they're taking aborted babies, they're keeping them alive long enough after they abort. How does that process work?
I don't know that right now in the United States that aborted babies are being used for organ donors. But certainly their organs are being removed and used for research. In China, there have been reports, and this is just reported, that they actually are using, say you're a high Chinese Communist Party official, you might want an organ, that they actually are creating babies via surrogacy as an organ source in China.
Seriously?
Seriously. Yeah, the Doctors Against Forced Organ Harvesting just had a webinar, and this was brought up that this is apparently taking place in China.
So they're creating babies through
baby
surrogacy.
Farming.
And then these babies are born and they're just taking them in
for organs.
Seriously?
That's the report. That's the report. Yeah, it's always worse than you know and later than you think.
Yeah. Is that happening at all in America?
Not that anybody's aware of. No. But what people often ask me, and probably I should give your viewers this. People say, well, okay, Dr. Klessig, you've really shook me up here, and I'm an organ donor. I'm on the list. What do I do? So what people need to do is they need to remove their name at the state level, which you can do usually by a visit to the Department of Motor Vehicles. There's also a national registry, and so if you go on our website, respectforhumanlife.com, I actually have a button on the homepage. How do I get off the donor list? You have to remove from state and national registries.
We'll put that in the link in this podcast.
That's good. Be sure to tell your family what your wishes are. Okay, because this just was in the news, just yesterday, a case in New Jersey. A gentleman there had been an organ donor. He converted to Islam, and most people in Islam disagree with the idea of violating the body after death. So he removed his donor registry in 2025, last year. He unfortunately had a cardiac arrest, is brought to the hospital, declared brain dead. The organ procurement comes, and the family says, no, we're sorry, we're Islam. We don't adhere to that. He removed his name. The organ procurement person actually told them, no, I'm sorry, an organ registration is a lifetime commitment. Total lie, total false claim, and threatened to sue the family in court if they didn't allow that man to become an organ donor. Okay. Total gaslighting.
So they just made that. They just made that up, and they lied to scare the family.
Right. So
what is wrong with these people?
Thankfully, the family's niece worked for a state senator out in New Jersey, and was able to make a call from on high and got it stopped. But it turns out this same New Jersey organ procurement organization is under federal investigation. The House Ways and Means Committee had sent them a letter last year because they did have a history of pressuring grieving families and taking organs from people who appeared to be biologically alive. So they are under. So if another OPO goes down, it's probably going to be this one out in New Jersey. So tell your family so they can advocate for you, especially if you have removed these things. Don't let some organ procurement people gaslight you into thinking that that's a lifetime commitment, because it's not.
That family, they should be able to
They should.
I don't even know what they should be able to do.
The third thing you need to know is the Uniform Anatomical Gift Act was revised in 2006. And it now says if you don't have a specific refusal to donate and you come into the hospital, you're incapacitated, your family cannot be found in a reasonable amount of time, it empowers the hospital administrator to donate your body or organs on your behalf, lacking a specific refusal. So not only do you have to withdraw your names, most people in the US think we have an opt-in system, you have to register to be a donor. Actually, it's an opt-out system because of the Uniform Anatomical Gift Act. You have to document a specific refusal. And where I would put that, I'd put it in your healthcare power of attorney document. I would put it in your electronic medical record. When next time you see your provider, say, I want it in my electronic medical record. I refuse to be an organ donor. And they'll say, gee, we've never been asked to do that before, but they can.
Yeah.
They can. And the third thing is...
well, they work for you.
That's right. Well, supposedly.
So, yeah.
and then we do have our friends at the Healthcare Leadership Advocacy and Leadership Group have a very nice wallet card that says, I refuse to donate. And we have a link to their website and you can get one of those from them. So carrying a wallet card is also an added level of precaution.
Yeah. Yeah, that makes sense. That's very helpful. I always found it weird that you go to the DMV and they'd ask you if you wanted to be an organ. Even when I was in high school, I was like, why are they asking me this at the DMV? This is like a place.
Did they give you a consent form? No consent? No, they just have bright posters.
Well, they tell you that they basically make you feel like if you don't do this, you're a bad person, you hate people. And you're like, I don't even know what I said. I have to look into all this because I haven't. My wife did your steps already, I think, for her and the kids. But that they don't even ask you questions. They just tell you basically there's this sort of stigma around it. Like if you don't do this, you're just a bad person. So go ahead and do it. And then you have the signs all over the wall. They're like, okay. So that's not good. Wow. Yeah, there's a lot here to talk about, but I just appreciate you talking. I think this is a good starting point for people. I think that understanding that this is what's happening behind the scenes, or that there's a lot of language around this, and that there's good reason to be skeptical of what you're being told don't just believe everything at face value. Look into the definitions of what things mean. This requires for people to do work. They actually have to do work and not just trust people on the basis of they have a piece of paper from Harvard or wherever they went to school. That doesn't make them a moral authority on life and death. And I think that that's a really good principle for people to be thinking through. So I appreciate what you're doing.
I emphasize to people, nobody likes to think about death, right?
No,
but you need to think about these things before crisis strikes and it's the worst day of your life. You're sitting in an ICU with a loved one on a ventilator, and that is not the time to start looking at this. So that's why I have, the website respectforhumanlife.com has a lot of information for people. If you go to my YouTube channel at Heidi Klessig, MD, I have short and long videos. I mean, I have a series of 5 to 10 minute short videos. What is brain death? What is donation after circulatory death? We haven't even talked about the ghastly practice of normothermic regional perfusion, or NRP. What is tissue donation?
What is NRP?
Oh, you want to hear about NRP?
Sorry.
You should hear.
You tell me. I will keep asking.
All right, you should hear about that.
Explain
so
that.
NRP is very controversial even in medical circles. So it is a variation of the DCD, or donation after circulatory death protocol. What happens, of course, as we mentioned with, say, Misty Hawkins, and she's gasping her life away for 103 minutes, it's very hard on the organs. So doctors want to know, is that heart really going to be good enough to put into somebody else? So one way to be sure it's good enough would be to resuscitate the heart, give it some good, warm, oxygenated blood and see if it pumps well. But if you resuscitate the person on the table, of course, they might wake up. Yeah. So NRP begins with doctors clamping off the circulation to the brain, making you brain dead on purpose. Then performing a full resuscitation on your organs to perk them up with good oxygenated warm blood to make them suitable, to see if they're suitable for transplantation. So this technique is controversial because it plays fast and loose with the definitions of death under the Uniform Determination of Death Act. So first, you're allowed to become pulseless. So your death is now legally defined as the irreversible cessation of circulatory and respiratory functions. Now, it's not really irreversible because we're about to get your heart started in your own chest, but we don't want to be, we don't want to be accused of murder. So now what we do is we clamp off the circulation to your brain, making you brain dead on purpose.
Yeah.
Now your death is defined under the Uniform Determination of Death Act's second arm, the irreversible cessation of all functions of the entire brain, including the brainstem. So now when we restart your heart in your own chest, you can't sue us for homicide.
That is homicide. That literally is homicide. That's crazy.
It literally is homicide.
I think as you're talking, I don't think we should be dying in hospitals. I think that we should, actually, I thought this beforehand, so but I'm thinking it more. I don't think we should be dying in hospitals. I think that people should be dying in their homes, and they should just let natural causes. Because even to our argument earlier before that, as we disagreed on somebody that has a ventilator or whatever, and they choose to die, the reason why I have a strong opinion on that is because I don't even think they should be in that situation to begin with. I just think this obsession with staying alive as long as humanly possible is a result of sin. I think that that's you should want to be alive within the good created order that God has created. We don't have that. We have a corrupted, sinful world, and allowing for nature in its corrupted form to kind of play itself out, and you die around your family in your home like everybody else died for all of human history. All of these conversations we're having, we wouldn't be having those conversations, all of these definitions and terms, and there's a whole literally millions and billions of terminology that people don't even, how could you possibly know all this stuff? And it's all from the fact that we just decided arbitrarily at one point that trying to get people to live longer than what God had intended them to live is good. And I don't even know if that's true. Of course,
I think it's an individual case by case decision. I mean, we're not going to solve everything by a one size fits all approach. We're not all alike. And so I think, at the end of life, with prayer, with getting the best advice you can, everyone needs to be able to, make that decision for themselves. And that's why making your wishes known ahead of time to your family makes a lot of sense.
I know. I just think people need to be more sophisticated in their thought process, because it doesn't seem. Who's gonna say I want to do the natural way? When you're being pressured by all of society from the age of 0 on to opt into the medical industry, literally our whole economy in America is tech and medical. I mean, those are the two main driving factors. We used to have industry. We put that all in China and India. So we don't have industry anymore. We don't create things in America. It's just keep people alive and build technologies. I mean, Epic is in Madison. Build technologies that basically either administrate this or help continue this. And that just doesn't, I don't know, that seems like a highly reductionistic economy, and it seems like it programs people into believing particular things about life that just aren't true, that God didn't intend. And I don't know if I know that I don't take the highly individualistic, I don't think that this is a decision that individuals should be making. I think that this is a decision that they should be consulting their family, their churches, and the Bible. Those three things, people, whatever. Yeah, those three resources. And churches should be making, this is where the Catholics, I think, did a great job with, I don't know what you would think about this, but with the pill. The Catholics, and saying, all forms of, I can't think of the word right now, all forms of
interventional contraception.
Yeah, sorry, contraception are wrong. I think that they were right about that. I just don't, because these are all situations where people think that these are gray areas. These are the intangible mysteries of life that God has always been in control of. And part of the fall was that man's desire was to usurp God's place as God. And then the woman's desire was to usurp the man's place as the head of that relationship. So it's everybody's trying to usurp each other. This all feels like that's what this is. And the churches should be saying, actually, if you want to be in our confessional church, you can't do this, period. Sorry to just throw that out of nowhere, but that's just what I think.
We
I don't
should
know.
be having these discussions. These
Yeah.
are good discussions to have. I was joking with someone the other day. Benjamin Franklin
Yes.
famously said that the only certain things in this world are death and taxes.
right.
But now that death has been redefined,
Exactly.
the only certain thing
Our
is taxes.
Exactly. Right. That's a really good point. Yeah. Okay. I will finally end it. This is like the fourth try, but I think we've covered all the main things. And I really appreciate you talking. I appreciate you writing these books and telling people about this, because I was completely unaware of this until we heard about what you were writing and what you've been saying. So thanks for doing this, and also just thanks for talking. I really appreciate it.
Thanks so much for the opportunity. I've enjoyed the discussion.
Yes.